So thank you everybody for joining us. We are looking at our Research Quarterly webinar, and tonight's topic is on workplace violence and harassment. And we're talking tonight about a novel strategy to encourage open discussion about every incident. This webinar is going to share an intervention strategy which increase healthcare worker comfort in sharing these experiences and a new restorative approach to respond to workplace violence and harassment incidents in home healthcare settings. We invite you to share your ideas and submit your questions in the Q&A or the chat found in the toolbar at the bottom of the screen. We have time for discussions and your questions to be answered throughout the presentation and following the presentation. I'm now going to ask Dr. Nancy Snoblin, the research consultant at WeRPN, to begin our evening.
Hi, everyone. My name is Nancy Snoblin, and it's my pleasure to introduce you to this wonderful speaker we have here with us this evening. I'd like to begin by acknowledging the land on which we gather. It's the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. For thousands of years, Indigenous people inhabited and cared for this land, and we are grateful to have the opportunity to work on this land, and by doing so, give our respect to its first inhabitants. May we dedicate ourselves to moving forward in the spirit of partnership, collaboration, and reconciliation as we learn together and contemplate the possibilities that lay ahead. In tonight's session, you'll hear that although healthcare workers often choose not to report their experiences of harassment and violence, VHA's team developed an intervention strategy which increased healthcare worker comfort in sharing these experiences and are implementing a new restorative approach to responding to workplace violence and harassment incidents in home healthcare settings. It's a very important topic to ensure safe, quality work environments for care providers and clients. So now let me introduce our speaker, Dr. Emily King from VHA, and she's the Director of Research there, where she leads a research team focused on creating evidence to inform better care for home care clients, create safer teams of care providers, and build toward a more connected health system. As an experienced home care researcher with backgrounds in mechanical and biomedical engineering, a major focus of her current research is on pursuing opportunities to improve safety and quality for work life for home and community care providers. Emily's academic preparation includes a master's and PhD from the University of Toronto and a bachelor's degree from the University of Waterloo. She currently holds assistant professor status in the Division of Occupational and Environmental Health at the University of Toronto's Dalla Lana School of Public Health and adjunct assistant professor status in the University of Waterloo School of Public Health Sciences. That was my first university, Emily. So welcome, Dr. King. We look forward to your presentation, and I'll let you take it away.
Thank you so much, Nancy. Let me get my screen sharing sorted out. Does that look right?
Yeah, it looks great.
Okay, perfect. So thank you all so much for taking a bit of time out of your evening to come and listen to what I've been learning about workplace violence and harassment and what VHA is trying to do to address this and encourage more open discussion of every time this is experienced. And there we go. So I'm based in the home care sector. And that's been the focus of my research and now sort of my research and implementation work for well over a decade. And today I get to share with you a set of projects based in this sector that have paved the way for more open conversations about violence and harassment. So the first project I'll share is exploratory. It's about better understanding why community-based providers choose to share or not share the negative experiences they have while providing home care. The second is interventional and action-oriented. I'll share a pilot project, so an intervention that we designed to tackle some of those reasons people choose not to report and to make it easier and feel safer to report. And then I'll share an additional piece that we've developed to support supervisors in responding to the reports that they hear from providers, again, with the intent of making it feel safer and more meaningful to report. And I am delighted to say that this is work that we've done a pilot, we've developed an additional resource, and now we're launching this across our organization, initially for our personal support workforce, which is about 1,700 PSWs and the many RPN leaders who support them as supervisors and as clinical leads. And so this is happening, and I sincerely hope that I will be able to come back to you in maybe a year or so and share the results of the evaluation that we'll be doing with support from WeRPN as we roll this out. So today, my objectives are to identify why home care providers often choose not to report violence and harassment. I will share about a multifaceted intervention that did successfully challenge the normalization and underreporting of violence and harassment at our organization. And I'll introduce a framework for respecting reporter preferences when responding to workplace violence and harassment to try to provide the supportive responses that people are looking for. Jen, would we be able to run the polls just to get a sense of where people are coming from in terms of their backgrounds with this subject matter and their sectors?
I can. Now, you're okay if I launch it as one whole poll?
That's fine. Yep, let's go for it.
All right.
And Jen assured me this is one whole anonymous poll, so please answer honestly. We will not be calling out anybody's individual behavior. There we go.
There we go.
So I ask, what sector do you work in? And I think you may already have shared that. Are you in a leadership, direct care, or indirect care role? Have you experienced violence and or harassment from a patient, resident, or client, or their family member? Or from a coworker? And have you ever chosen not to report it? And then, because we're launching all as one, if you have thoughts on why people from your organization choose to report violence and harassment and choose not to report violence and harassment, that would be most appreciated. So I'll give you a moment for that. I have no way of monitoring the poll as it comes in. I assume you do, Jen?
I do. We're
Super.
getting responses here.
So thank you for sharing as you're typing there. And as you're typing, I'll just move ahead a slide and share, if I'm still able, yep, that this is work to which many people have contributed. So I have a list of collaborators on one side of the slide and organizations and funders across the rest of the slide. So this is a set of large efforts and large projects. And so I appreciate the contributions that everyone has provided to what I think is a meaningful body of work that I am able to share with you today. It's a good time to do a roll up, Jen?
So I'll just start at the top. There's people still answering it. So I can share that as the results are coming in, we have a good mix from hospital and long-term care here with us today. We have some from other sectors. We're seeing home care come up now. So the poll's still quite active.
Oh, fantastic.
The majority of our attendees here today are from direct care roles. We do have people from leadership and also from indirect care roles. The poll for experiencing violence and harassment from a patient, resident, client, or their family member is mixed right now. Again, answers are still coming in, but we have both harassment and violence for 40% and no for 40%. And we have some that have experienced harassment. From a coworker, it's divided. So 60% are saying no. We have about 70% saying both harassment and violence, and about 17% saying harassment, and the poll is still moving. So we'll leave this open, and if you're comfortable to go ahead, and we'll have our contact information available afterwards as well, if you had any questions or wanted to share anything with our speaker or with WeRPN, or questions for our professional practice team. Have you chosen not to report violence or harassment? That's divided. So 40% says yes, 40% says not. Oh, okay. If you scroll, Courtney, on your poll, can you move it down? The poll's gone. Is anybody else having a hard time with the poll? Okay. Well, we'll put the poll back up. So I'll just share what we have right now, and then we'll look at the poll feature after, because it's still showing that it's launched on my end here. So we have, sorry, have you ever chosen not to report violence or harassment? 40% are saying yes. 40% are saying not applicable, and we have 20 reporting no. I have to pull up the short answers here in a minute. Okay, and then, there we go. Okay, so I've ended the poll, and I'll take a look and see if we can get that back up. And
So it sounds like we have quite a diversity of experiences on the line. And I will say that the relatively high prevalence is, as you'd expect, pretty typical of, I think, all healthcare environments. And the mix of choosing to report and choosing not to report is also pretty typical of what I've been seeing. And so I will say up front, the majority of my work is directly with personal support workers. I think once we've done the big rollout to personal support workers, I've certainly been spending more time understanding the perspectives of home care nurses as well. And I believe that many of these issues are common. And I'm really looking forward to a series of conversations with Marilyn about how we can extend these resources to really work for the home care nursing workforce and for other sectors. And I'm interested in your thoughts on that as well. So please feel free to be very active in the chat as we go. Pop in the thoughts as you have them. Jen will stop me if I need to be stopped, because it's a question that I need to answer urgently. Otherwise, we can have a lively discussion at the end, and that would be fantastic. For now, I will move forward. So healthcare workers, regardless of sector, often experience high rates of violence and harassment. There is a normalization and a toleration of harassment and violence seen as just part of the job. There is a culture of underreporting, and the violence negatively impacts care. In home care, we don't know what's behind that door. So when a provider first approaches a client's house, they don't necessarily know what the environment will be like. They work alone in the client's homes. They often have very limited information about what to expect from the client, the family, and the environment. We know that about half of clients will have some degree of cognitive impairment that may lead to responsive behaviors. About a quarter of people with cognitive impairment may exhibit responsive behaviors. And the community-based workforce includes many vulnerable workers, including many immigrants, women of racialized background, and often fewer resources. So the first question is, what influences community-based PSWs' decisions to report or not report their negative workplace experiences? So I based this on a subset of a larger project that I did called the PSW Safety in the Community Study. It was a one-year prospective cohort study with community-based personal support workers and home support workers. The full cohort was 876 individuals, of whom 230 chose to participate in a series of surveys that I circulated. Those who did were predominantly female, about 2/3 white, with many additional identities represented. And I did extensive engagement with this group through team meetings. I visited every group 3 times over the course of the year to share about the study before we started, share findings at the midpoint, and then share back findings at the end, and get support from the people who participated with interpreting what I was seeing. There were frequent emailed survey updates. Surveys were at baseline, weekly if people chose to, and closing. And sometimes there was participant-initiated phone or email contact as well, where they had other things they wanted to share or wanted advice on. I'll focus now on a bit of data that came from very brief weekly surveys that asked about the experience of work that week, including pain and whether it influenced work and whether it was reported, and any abuse, physical, verbal, sexual abuse. Was it perceived to be related to a disease that the client or family member had? Did they continue to provide care? Did they report it? And is there anything else they want to tell us? And the surveys were analyzed thematically by two coders. And the reason that there was enough for thematic analysis here is that people did want to share more. They wanted to share more about the experience, and they want to share more about their choices. And so that's really what I'll be sharing with you today. And pain and abuse are dealt with together because the rationales were very similar. I'm going to focus on the abuse-related findings, but I'm going to say that a lot of the same applies to pain experienced at work. So, reasons for not reporting. Number one is fear of negative impact. If the response to reporting a negative experience is to remove the client from the PSW schedule, just separate them, sure, it's dealt with the problem, except then there's the personal support worker who is paid per visit, loses the client, and therefore loses care hours and loses income. It's a very direct negative impact. For some, they feel that there's a risk of receiving even more challenging clients. And for many, these risks were perceived to outweigh the potential benefits of reporting. Now, I don't report the abuse anymore because I've been losing hours and I cannot afford to lose any more. They had compassion for clients, particularly those with cognitive impairment who didn't appreciate the impact of their actions. And they had a commitment to continuing to provide high quality care. And so they didn't want to risk separation and they didn't want to get the client in trouble. It was just something that might happen. So I have nothing to say because I understand that clients are confused and agitated sometimes, and they may lash out. And then a perception that it's just part of the job. An expectation that their work would include harassment or violence from clients, and this is a finding from other literature as well, is that this is built in as an expectation in a lot of healthcare work. And the normalization led to a feeling that there was no point in reporting it, that nobody could help. And the unfortunate consequence of non-reporting, I felt forced to continue seeing this client and I got abused a second time. So the next piece I'm going to tell you is taking what I learned from that, taking the many very reasonable, very rational reasons people choose not to report, to try to design a new approach to promote openness and encourage reporting. The reporting itself needs to be quick, meaningful, and not lead to blaming the worker or reducing their income. Reporting violence and harassment is part of the job, not the violence and harassment. So this is a multi-part intervention that we developed at VHA to try to address these things. And there were policy updates supporting all of it. We've got three streams here: education, screening, and reporting. So for education, this focused on how to respond in the moment and on role perception and motivation for reporting. Why is it worth it? Why reporting is important regardless of a client's medical condition. The value of reporting to team members. If they know, they can be safer, they can be prepared. And how supervisors will respond to the reports was another piece to share. We had a screening component before the first client visit is scheduled, which meant there's very limited opportunity. It had to be a very brief addition to the scheduling coordinator's script because that's the only guarantee or the only contact we can guarantee will happen before the PSW goes in the first time. A brief, simple reporting system, end of visit reports that the PSW can use to indicate whether anything happened, whether they want supervisory follow-up, and it had PSW's descriptions of the event and its management that would be shared directly with peers. No delay, no mediation, straight to peers. And finally, we used a monitoring dashboard to identify patterns, changes in client patterns that might indicate unmet clinical needs, and potentially opportunities for additional training. So of those elements, I'm going to focus on, I'll share a bit about the screening briefly, and then I'll focus on the end of visit reporting. So the screening questions, as I said, they had to be injected into a script that's already plentiful enough. And so we had to keep it brief. And we boiled it down to Are there any concerns or anxieties about having a home care provider visit? It's a good client-centered opening question. And the follow-ups can be, we want to make this visit go as well as possible. Do you have any suggestions to help make this a better experience? So this is an opportunity to open a conversation, especially with care partners at home, as to things that might be triggers for the client receiving care. And again, explicitly, are there any triggers our providers should be aware of? The second question was, as part of the process to ensure staff, clients, and family are safe, we have a screening process to assess for any risks in the home. And then being aware of the potential risk can help providers to manage them. So are there pets in the home? Please remember to put them away. Does anyone in the house smoke or vape or use any tobacco or marijuana products, and remind them not to do so indoors in the period prior to each visit? And then, is there anything else that might be harmful to people coming into your home? And we could clarify with, concern about needles or sharps or any weapons in the house, trying to approach this one gently. The end of visit reporting had to be very, very brief, and our request was for people to fill this out at the end of every visit. And the question was, did any of the following occur during your visit? Is there any violence, harassment, a workplace incident, or something else? No or yes. If it's no, thank you for reporting, we're done. If it's yes, was it verbal aggression, harassment, violence, a workplace incident, or something else? How easy was it to manage? Recognizing that many situations go unreported because nobody's dealt with them. It's within their professional skill. They know how to do this. They've had gentle persuasive approaches training, and they're good at it. So was it easily managed? Was it challenging to manage, or do you need supervisor follow-up? We asked for a brief description of the events and any strategies that the reporter used that the teammates may find helpful. So again, respecting the expertise of people who have managed a situation, that they know their clients, that they know how to help them calm down. Please share those strategies for the next PSW who goes in. Please share that strategy for whoever comes in to fill in when you're off sick or on vacation, or just the person who provides afternoon care. And finally, do you want a supervisor to provide further follow-up? So we had that in 2 places, just to be sure, in the pilot. Tell you about the evaluation of this, which is also published and available if anybody would like the paper. It's open access, so anyone can grab it. And so the data sources for this, where we had a 32-week pilot with one of our care teams. We had moderate integration into the workflow. So report invitations were sent out after every visit for people in private homes, or at the end of the workday for people in retirement homes. But it was a separate system. We couldn't build it into our client reporting system up front. Over the full 32 weeks, about 7 months, 69 PSWs provided 410 clients with over 55,000 care visits. 110 of those clients and 23,000 were in retirement homes. The rest were in private residences. And so for the data sources I'll be drawing from, we had baseline and closing surveys about experience and perceptions. We had end of visit reports directly. We had attendance records from the education. We had the coordinator screening notes, and we had some key informant interviews. So of the 36 individuals who chose to complete a voluntary baseline survey, they were mostly women, a very diverse group from an ethnic and racial perspective. Most people had previous experience of violence and harassment, predominantly client to worker or family member to worker, like client's family member to worker. A third had experienced but not reported harassment, and a fifth had experienced but not reported violence. Normally, the choice to not report was based on a client's medical condition. All right. So we rolled out education. We offered 7 synchronous training sessions. We managed to train all team leaders and about 2/3 of PSWs. It is very hard to do synchronous training with community-based workforces, so I think this is fairly typical. For screening, I had more boxes there. Okay. We were able to screen most but not all clients. Sometimes initially the coordinator forgot early on, or it was not appropriate for retirement resident clients. So sometimes the screening questions were deliberately skipped, depending on where the client lived. Typically, the screening went smoothly for the clients in the private homes, with the exception of a few clients who usually there was a language barrier and they were offended by the questions and responded aggressively, in which case the screening coordinator would sort of back off, make a note of that, and just move on. With regard to the reporting, so as I said, it was imperfect integration into workflow, despite which 3/4 of PSWs provided at least one report. So they knew how to use the system. Just under half of PSWs submitted reports for at least a quarter of the opportunities. So that's not a bad level of engagement for something that's not well integrated into workflow. Reports were submitted overall for about a third of opportunities. Over the 7 months, 21% of PSWs reported incidents. Overall, 11% of the PSWs in our sample reported verbal aggression, 4% reported harassment, 3% violence, and 3% other workplace incidents. Interestingly, for 59% of incidents, the reporter declined follow-up. Like, I've managed this, but here, I'm sharing what happened. And those are normally incidents we wouldn't hear about if they've been managed and if follow-up is not necessary. That's additional insight. 78% of the reports included details about the event or incident, and half of them included client-specific strategies for managing. So an example here, he has the inappropriate tendency to touch, or the tendency to touch you inappropriately while assisting him to walk to his bed or the couch. With the help of his private caregiver, we always remind him that his actions are not acceptable and not to do it. Or in a challenging event, say, I ask him to calm down and I speak softly in a calm manner. So sharing the strategies that they've used to de-escalate these difficult situations. In terms of at the end of the 7 months, how did people feel about the experience of participating in this pilot? PSWs found the system quick and easy to use. So that was a first win. 100% of those who reported incidents believed they were taken seriously, and this was an improvement on our baseline. 91% who requested follow-up were satisfied or very satisfied with the quality of follow-up. The remaining 9% were neutral. And PSWs perceived the reporting tool as valuable. They did support integrating it into the usual workflow, so into their regular end of visit reports that they submit following a client visit. In terms of findings related to culture change, it's a really important idea here. We saw that comfort sharing concerns about treatment at work increased. And despite this, some PSWs were still choosing not to report some incidents of harassment or violence because they were confident in how they'd managed it, they attributed it to a client's medical condition, and they wanted to prevent further conflict. And so this told us that this moved the needle on reporting culture. This was helping, but we're not all the way there yet, which probably isn't surprising. So our takeaways were that the intervention was well received and effective. We considered this to be fairly high engagement, given that it was not perfectly integrated into workflow, and we received positive feedback. There was increased comfort and openness discussing workplace violence and harassment, which is a good shift. And there was increased confidence in managing incidents, which is another good shift. The end of visit reporting increased from a leadership perspective, the visibility into PSW's experiences during care. It's interesting to note we had a change in supervisor in this team halfway through the pilot, and the new supervisor who came on found that she was able to gain insight into her team's experiences more rapidly, and it helped her know where to focus her attention when she joined the team, in which clients to reach out to and meet first, perhaps, who could use additional support off the bat. So she was very supportive. It highlighted opportunities for intervention, unmet client needs. So, times when the responsive behavior might be related to pain during transfers. And nobody had really reported this because it was pretty understandable. There was pain during the transfers. But the clinical lead was able to follow up with the palliative care physician and talk about improving pain control. So an opportunity to truly improve care based on what otherwise would have been hidden incidents. And it was perceived as both valuable and not burdensome. It was difficult to reach all PSWs with synchronous education, so we've added an asynchronous option. And the screening approach was generally well received. Why do we think this worked? We think it worked because PSW's expertise is respected and can benefit their colleagues. They report to inform and support each other, and that's really important. PSWs know and remain in control of the process, and leadership's available to provide support. Now, leadership for the pilot did have a lot of wraparound support on a weekly basis. And as we're looking at rolling this out, we were talking to other supervisors about the additional supports that they would want if they were receiving this many reports and managing reports where people didn't want follow-up. Given that, supervisors know they have obligations under the Occupational Health and Safety Act to take every report seriously and to respond to it appropriately. So we developed a response framework to support the supervisors. The goals were to support the supervisors to meet their OHS obligations while respecting providers' desire to minimize follow-up, to help ensure that responses to providers' reports are transparent, predictable, consistent, and supportive. And we've added a new, what we call restorative pathway that supports repair and maintenance of valued client-provider relationships. Home care providers work so hard to form good quality relationships with their clients and families. And they really don't want to lose that in most cases. And if the relationship can be repaired and supported, then that's often a good outcome. How was it created? It was informed by research, and then it was co-designed with supervisors, personal support workers, including our personal support leaders, coaches, and union stewards, members of our best practice and education team, representatives from human resources, regional managers and directors, and a client partner as well. And we came up with this, which is an overwhelmingly large but very detailed job aid. It kept getting bigger as we kept adding pieces. People wanted a more comprehensive resource, and this is it. To break it down for you, I guess up at the top, we have a non-urgent end of visit report is received with support preferences indicated. If this is an urgent event and affects the willingness to go to the next visit, the PSW calls the office. We need a more rapid response. But with this, if support is not requested, we provided guidance for responding for the supervisors. If support is requested, we collected supervisors' best practices to provide guidance for investigating. If it was necessary to separate the client and the provider, we provided guidance, again, organizational best practices from across the many people who participated to lay the foundation for a new, safer client-PSW relationship with the new PSW. If the relationship was one that the client and the PSW wanted to work on repairing, we provided a new restorative pathway for supporting and repairing the existing relationship with a focus on identifying and addressing unmet needs on both the reporter's and the client's part. We provided guidance for wrap-up and proactive follow-up, and also some resources for ongoing monitoring. So I'll take you through the three of these that are, I think, the less common elements, just for time reasons. So we'll start with what to do when support is not requested. Acknowledge the incident. Thank the PSW for reporting and offer support if their preference changes. They can always have support if they want it. Document the follow-up and reach out to the PSW if further information is needed. If appropriate, maybe they shared a really great strategy and you don't want to ever have that disappear from the client records. You can add it to the service plan to inform PSWs of potential challenges and of great strategies for managing that. And if appropriate, notify the funder. Sometimes a situation looks like it might build towards one where we might need a pause in order to come up with a safety plan for continuing to provide care. And laying the groundwork early can really help. So our supervisors emphasized that having this documentation, having this longer term record was going to be very helpful if that was something that might be necessary in the future. The restorative pathway is the next piece. Oh, and I will say, as a job aid, we do provide a template email highlighting all of the things that a supervisor would need to say to make sure that they meet their obligations and that they are supporting the report appropriately. So for the restorative pathway, support in repairing a relationship, you might have heard of restorative justice or restorative approaches being used to address cases where there have been medical errors. It's also popular in education. and in sort of police community relations, trying to repair those. And in general, the focus of restorative inquiry is to address harms, meet needs, restore trust, and promote repair for all involved. And it can be used in many different fields. As I've said, it's best suited to situations with no clear malicious intent and with parties who either can't avoid each other or often in the case of home care don't wish to. And the focus of this pathway is on mediating through joint meetings between the PSW and the client, if that's what they wish, or individual conversations with the supervisor, if that is more comfortable for people, to discuss people's perspectives on what happened, the feelings, and unmet needs and goals. An element of the restorative process is to encourage acknowledgement of harms, and so encourage acknowledgement of the impact of a client's actions on the PSW and on their work environment, to develop strategies for moving forward with a positive relationship. And this culminates in the creation of a restorative plan that focuses on addressing unmet needs. And we've got a big focus on what supports might the reporter need. Is that for the supervisor to reinforce client rights and responsibilities and to support boundary setting? Does the reporter need coaching to support them in dealing with the situation? Is there additional training that would help? Or do they need psychosocial support to help them in managing their feelings about the incident? On the client side, are there behavioral supports that are necessary? Sometimes pulling in a behavioral support OT can help to identify strategies to mitigate responsive behaviors and to minimize those. They aren't inevitable. There may be clinical supports like pain management that are required or additional care that is needed. There may be social supports that are lacking. There may be an opportunity to connect with the funder to advocate for additional time or services. And then at the end of this, hopefully we get to a point where the relationship can continue. And I'll say that many of these elements are not that different from what supervisors currently do, from what experienced supervisors currently do. But this can help people to bring it together in one cohesive, predictable approach that can be used across our organization and can hopefully give people confidence that this is what will happen. In terms of ongoing monitoring, we have a new behavioral notes section of a client record in which the 5 most recent incidents and strategies for each client are visible to other providers within the client record. So PSWs can go in and see what the last PSW reported. Direct peer-to-peer communication. We have the option for behavioral flags that can be set by the supervisor or clinical lead to alert providers to new or ongoing risks. And a supervisor dashboard, one from the pilot is seen on the right-hand side here, which enables a review of trends to enable proactive support. If there are clients with frequent or escalating reports, clients with increasing numbers of providers on their do not send list, that might be a sign that something's going wrong. Or providers who are experiencing frequent or greater difficulty in managing clients who may benefit from additional training, coaching, or support. Okay, as I'm coming to the end, overall, what we see is we've designed a novel workplace violence and harassment reporting and response system, and we've tried to address each of the reasons that people commonly choose not to report. So we had a fear of negative consequences that outweigh perceived benefits, including a loss of the client, hours, income, and a fear of receiving more challenging clients. So to try to turn it around, we have a transparent response process which respects reporter choice, focuses on unmet needs through a restorative process, offers transparency. If a client is removed from somebody's schedule, that was very important to PSWs, is please tell me why. Please let me know why this happened. And we can prioritize replacement of hours. And so this isn't something I could show you before, but we do have a policy that prioritizes replacement of hours if they are lost because somebody experiences harassment, violence, discrimination, or if the problem was on sort of boundary setting challenges, which are very common in community-based personal support work. There is compassion for clients who may not appreciate the impacts of their actions, not wanting to get the client in trouble. The reporting is not punitive. You're not getting the client in trouble. You share the incidents and strategies to inform colleagues and to help the client to access additional supports. So this is a way of supporting the client and supporting their care. You're not getting them in trouble. There's a perception that it's just part of the job, so there's no point in reporting. It may sometimes happen, but it's not in the job description. Reports can be used to improve client care and provider safety, so there is a point to reporting, even if it's managed. And then there's the perception that reporting is not worth the fuss. We've heard, I don't want to spend 20 minutes waiting on the phone for my supervisor to be available and then talk it through and then enter the email. I just don't have time. Reduce the fuss. We've tried to create reports that are as quick as possible and to respect and to allow people to indicate their follow-up preferences that we'll respect if possible. This has now been integrated into the regular workflow. And so that goes live in about a month, and we'll see how that goes. But it's been integrated into the regular workflow. So it's just part of saying, yes, I did the respiratory screening. Yes, I completed care. No, there wasn't an incident. Close out the visit. And as a final point here, reporting workplace violence and harassment is part of the job. Reporting it is. It improves safety for colleagues and care for clients. And this is the message that we're trying to carry forward in our full-scale implementation. And so this is what we're trying. And as I said, we are expanding this to our whole organization. All the PSWs in our organization first, and then hopefully we'll be able to expand to other groups if this is successful. And I hopefully will be able to come back to you and tell you how it went. But at this stage, we're very hopeful, and we've been receiving very positive responses from all of the people we've engaged. What do you think in your context? Would any of these ideas work? Do you see the potential for transfer? I'm interested in a discussion now, and you can find me at emily.king@vha.ca if you'd like to have a discussion offline about it as well. So thank you so much for your attention. I'll turn it back to you, Jen and Nancy. And Marilyn, I think.
Thank you so much, Dr. King. Wow. I have my nursing reflection going where I've just experienced it myself, and I've worked with so many of colleagues, PSWs and nursing, who do experience that fear or will be so compassionate for the person in their care that they can rationalize it or justify why they're accepting that experience, and then it comes into that normalization. The chat is getting busy here, so I will share some of that. But I think the tips as an RPN and working so closely with personal support workers, your presentation is really bringing forward kind of our role and what we can do to help PSWs when they're bringing these issues forward. And if 52% of the people who pilot tested are sharing strategies for managing, RPNs play such an important role in helping disseminate some of that communication and strategies. So this is wonderful. We do have in the chat here talking about this reporting tool and the time of incident reports, the general standard, filling out the paperwork, submitting the incident report, and then the disappointment when nothing is getting done or the concerns or dismissed or minimized. And we had a comment earlier, Emily, that said that, they had a concern as well and had it minimized. Do you have any comment around that?
Yeah, I think that there is certainly a prevalent culture in healthcare of minimizing these experiences. And as you say, RPNs, I'm thinking especially in a community setting, play such a huge leadership role. And knowing that supervisors will be on board with this approach and that supervisors are willing to go forward with the message that this is not part of the job, that yes, this might happen, but that doesn't mean there's nothing that we can do about it. And we should report it so that we can identify what the root cause is and try to address that. That's a huge and terribly important part of the supervisor's job, is to ensure that their staff are safe and supported. That's the big one. And so to make sure that supervisors are on board to carry that message forward. And that's one of the reasons it's important to have the job aid and to have leaders at the organization. Our regional directors and our regional managers contributed to the job aid so that we can say we've talked to every director and manager who leads PSWs or who did at the time of the engagement, has looked at this, has reviewed it, and says, yeah, this is something that we can commit to. and can support the supervisors who they're working with in carrying that message forward. The leadership perspective is so important. And it takes a long time to build trust, right? If you had a bad experience at one organization, it will be difficult to have trust even at your next organization. So we know that takes time. And I think building up the record of successes and sharing and celebrating those successes is going to be very important.
Absolutely. Looking at the chat, we're getting some thank yous sent into the general chat and also to me directly. I have a question here. If a PSW is removed, what additional precautions are provided to the new PSW who goes into the home, so that the home where the incident occurred?
Yes, that is developing a safety plan. And I sort of minimize that, but I believe I have space to show you here. So this is tiny, but I will talk through this. So the supervisor assesses whether care can safely continue now or whether we need a service hold. And if we do need a service hold, they will go to the funder and request a service hold.
Okay.
If they believe that we can come up with a safety plan that will make it okay for another PSW to go in there, somebody with different experience, different perspective, different skills, because PSWs do have different skills, different specialties, then they can establish a safety plan and then be very open with the new PSW about what's happened in the past, about strategies for managing it, and about the supports that are available. We consider sending a PS coach to provide support on the first visit, and to make sure that the client, the family, and all involved PSWs know what the safety plan is. And importantly, that the PSWs know that if they do not feel safe, they can leave the client's home and they will be paid for the visit if it is missed due to a safety risk. They can call 911 if they need to. So to reinforce that message as well. So the supervisor has a big role in setting a safety plan, setting new expectations, and in making sure that the PSW is clear on their rights. Sometimes it takes longer to set up an appropriate safety plan. And in that case, we would request a service hold. If that's approved before the next visit, that's ideal. And then there's time to have a safety focused case conference with often it's the client, the funder, and the service provider organization to develop a safety plan that's appropriate to continue care. Sometimes that safety plan the hold hasn't been approved yet, and another visit is scheduled and care is needed. And in that case, we're bringing more of our resources to bear on making sure there's a temporary safety plan that the supervisor and the manager are engaged for support. We may attempt to fill the visit if we can, and if people are willing to go with full knowledge of what's happening in the home, if they're willing. Ideally, we would send 2 PSWs so that you have somebody to support you rather than being alone in the community. At least one of them must be experienced, and debrief them on the safety plan. And in that case in particular, it's particularly important to know that the PSW can leave the client's home if it is not safe. If you get to the door and you knock on the door and you're starting to see the warning signs and you do not feel safe to enter, that might be it. But to make sure that PSWs know that they have a right to be safe at work and that this will be supported. So that's the set of best practices that we could come to on this one. And I think it's reasonably robust, and it certainly prioritizes the safety of the staff going in. While also recognizing we need to try to provide care for the clients. They're vulnerable and the behaviors are rooted in something.
So I just shared Dr. King's publication based on this pilot test with you in the chat. If you're interested to take a read, it is available open access online, and it goes into some more detail about this process. Just looking at the time, and I know everybody's schedule is quite busy, I wanted to carve out a few minutes for.
May I respond to one more? Just briefly?
Absolutely.
Sorry, I just wanted to say, Courtney, you've shared with everyone that you like that it documents the PSW's response directly and that it's not all falling to the RN RPN. We are very sensitive to how heavy supervisory workloads are. There is so much to do. And we really didn't want it all to fall to the RN or RPN who was leading. It's so much. And it's hard to do everything in a timely fashion. And peer-to-peer sharing it really provides meaning, and it empowers the PSWs. It empowers the people who are actually in this situation and respect their expertise. And it's good for the supervisor's workload, as you say. So thank you for calling that out, because that's something that we were really concerned about.
Absolutely. And that's a great segue into introducing Marilyn to talk about some of the resources that are coming forward from WeRPN. And then if you have the time to hang in there, we want to give you some highlights of the research program as well, and what's happening here at WeRPN. And Dr. Emily, we have your email there. So if anybody has questions, and if anybody sends us questions directly, we'll make sure that they get to you as well. Marilyn, do you want to talk about some of the exciting stuff that's being done in this area at WeRPN?
Yeah, I will definitely jump in. Hello, good evening, everyone. I just wanted to comment on Dr. King's work. I was a personal support worker supervisor for 8 years, and if I had had this tool beforehand, I think it would have saved a lot of trauma that's been suppressed for so long from our staff. So I thank you for the work, and I'm looking forward to see what comes out of it. But here at the association, we're also in tune with workplace violence and what's happening with it. So currently on our website, we do have open access, a really good toolkit, but we thought it needed some updating. So we've done that. We've updated our toolkit. We've implemented a lot of more current information, things that are more applicable to the RPN. And this is being rolled out actually in the next week or so. So it's going to have a facelift as well, which is always nice to see. But we also have a webinar. We just really want to kind of do like a Reader's Digest version of it all. And we're going to be doing that on Tuesday, July 16th at 7 p.m. So mark your calendars. Really catchy phrase or title, Workplace Violence, a Reality for the Practical Nurse. So there we're just going to take a look at high level about what is workplace violence, identifying what some of those violences look like, and of course, how do we prevent and manage when they do happen? So that's going to be happening. We're very excited about it. We want your input. It's going to be an hour of great conversation and great learning, because we're all about learning. We want to make sure that you're taking that information away and implementing it into your day-to-day practice. So it's going to be up on our website shortly. So then you can definitely register, and we'll see you then. Thanks, Jen.
Great. Thank you, Marilyn. And you said, sorry, you said the registration link's not available quite yet?
Yeah, it's going to be registering is going to be opening by end of day tomorrow.
That's great.
Yeah.
Okay. And then shifting gears, I don't see anything else in the chat as we're closing up here. Just to give some updates about what's happening in the research department. We're very pleased to share that the 2024 to 2025 grants and fellowship, call for proposal has closed, and we are hoping to announce the new projects that are getting started here in July. We're working on the strategic research plan, and it's in draft. And what happens when we have a new research strategic plan, there is this governing body of Research Advisory Council who's going to go over everything with a fine-tooth comb, and they're going to give us some advice and some recommendations and help us achieve some of those mandates as we move forward. With this Research Advisory Council, we have a succession planning that's going in process right now, and there's opportunity for RPNs to join the council. And also right now we have a position for an academic rep. The positions will be posted each year. We want to announce a save the date for November 29th. We're having a Shaping Practice and Innovation, WeRPN's third research symposium. So that's coming together. So if you just want to mark that spot in your calendar, more information will be coming out soon. And then when it comes to how do we communicate the great work like Dr. King and her team at VHA has been working on? How do we have those updates? So it's really important that we have an opportunity to connect with you, RPNs as our members, and RPNs across Ontario on what is happening and the trends and issues that are being worked on and that are emerging from the evidence. So we do share this in our monthly Pulse newsletter, and we also have a bi-monthly research newsletter that goes out. when we're looking at partnering and supporting research like this, we do have a formalized recruitment and partnership process, and the form is available on our website. The research tab is there, and please have a look at it. We're continuing to update and post new information quite frequently. We also send updates on social media, so on LinkedIn, Facebook, we have X, which is formerly Twitter, Instagram. We're going to plan another research webinar in September. And then we also have an opportunity for RPNs where we want to support them to connect with researchers who are working on projects or who want RPNs. And I know VHA does this quite frequently. They really embrace RPNs in their research work. So we do have a roster that you can submit your contact information in your area of interest, and we'll help facilitate some of those connections whenever we can. And of course, you can always reach out to us at research@werpn.com. And that takes us to the end of our session. We are increasing evidence of RPN in the literature with other RPNs and our key partners, again, like Dr. King at VHA. RPNs are skilled health professionals who are leaders, who care, and who are dedicated to promote, maintain, and improve health, who provide comfort care and supports, and are contributing to research to make that positive difference. Tonight, we heard the newest innovation that's addressing workplace violence and harassment to develop safer quality of care on work environments. And again, we very much express our thanks and gratitude to our speaker, Dr. Emily King, and to her team. And thank you to everybody who joined us this evening. We look forward to you joining us again at our next research webinar.